Well, thank you, Judy, and again, thank you, Roger. That was terrific. The next session is going to be an hour of discussion. Is going to be done as a case-based discussion, and to coordinate that case-based discussion, we have with us my colleague, Dr. Tiffany Walker. Tiffany's an assistant professor of medicine at Emory University in the Division of General Medicine. She is an internist who actually also at the end of her residency did the EIS fellowship at CDC and then returned to academia. And she's based at Grady, where she serves as the principal investigator for the Grady post-COVID clinic. And she's also an investigator in the RECOVER study. She will be coordinating this panel in which we will have our prior speakers, but we'll also have the next two speakers joining us, and those will be Dr. Annie Antar, who is an assistant professor of medicine in Johns Hopkins, who will be speaking later about HIV and COVID and long COVID, and Dr. Kanisha Sinnerman, who is an associate professor of pediatrics at Duke University, and she will be later speaking about research on the RECOVER cohort and the studies being planned. So Tiffany, why don't you take it from here and welcome everybody to the panel.
Thank you, Dr. Del Rio. Thank you, everybody, for joining us. We hope that this will be a really stimulating case-based panel discussion. We have a number of really excellent discussants, as Dr. Del Rio mentioned, and we'll be going through long COVID diagnosis and management. We encourage all our panelists to give their expert opinion, and keeping in mind that we may disagree on some answers. This is a rapidly evolving area of research. And there's still a lot that we don't know, but we're going to go through some pretty high yield cases on what we might see in the long COVID population and how we might manage them. So moving forward, I have no disclosures to mention, and then our learning objectives, of course, are to identify management strategies for common long COVID phenotypes and to counsel patients on long COVID risk and mitigating factors based on the literature that we have available. So starting with case number 1. So this is a 35-year-old female. She has hypertension, but otherwise she's a very healthy individual, fully vaccinated, avid runner. She is presenting 7 months after an initial mild acute COVID infection. Her symptoms resolved, but a couple weeks later, she started to notice that she was having palpitations and weakness when she was getting up from a seated position. And it could occur even with just mild exertion. She is a waitress, and this is really impacting her ability to do her work, which is the only thing that she has to support her financially. She has had associated symptoms of generalized weakness. She has developed post-exertional malaise, which is something we see in this population where they have fatigue or malaise, kind of a delayed onset, an hour later, a day later after exercise. She has brain fog with forgetfulness, difficulty concentrating, and she notices these palpitations are associated with headaches and blurred vision. We do a comprehensive physical exam, and it is normal with the exception that she becomes rather tachycardic when she goes from the lying to standing position. Basic labs, including CBC, CMP, and D-dimer, are all within normal limits, with the exception of elevated inflammatory markers with a CRP of 15. So, what is the next best step in management of this patient? Would you suggest doing a transthoracic echocardiogram, doing a chest CT with contrast, tilt table testing, cardiac MRI, ventilation perfusion scan, or potentially something else? So go ahead and enter your responses. All right, it looks like the majority of the group is interested in doing a tilt table test based on these findings. There's a couple that are interested in doing a transthoracic echocardiogram, a few with cardiac MRI, and less with a CT chest with contrast or ventilation perfusion scan. So I think we'll start with Dr. Paredes. I know that you were just on the hotspot, but we'll start with you. Based on this patient symptomatology and what you know of long COVID, how might you work up this patient?
So first of all, I mean, the first thing we have to do with these patients is to rule out other diseases. I mean, I think long COVID is an exclusionary diagnosis. So we really need to think about other, so let's say classical reasons for tachycardia. And so I would really make interrogate her well, but I would not rule out, for example, even a transthoracic echocardiogram or even a chest CT with contrast sometimes. So I would not rule out also the other ventilation perfusion test or something like this to think about also possibly thromboembolisms. But yes, tilt table testing will come eventually, but we should not forget about other causes of disease.
Excellent. I agree. I think we see a number of manifestations in long COVID, including VTE, including new onset heart failure in that population. I'm curious, Dr. Siegelman, if you could unmute yourself and give us your thoughts. What would be your next best step in management? Do you agree that we should look for VTE or and do an echocardiogram in this patient, or would you agree with the audience to move to tilt table testing?
Yeah, I guess I agree with Dr. Paredes that now we're 7 months past infection. We're not told exactly when these symptoms started, but if there's any chance that this is something that happened in the interim, I would think about more emerging things first, given that's my bent. So maybe thinking about PE or myocarditis at the same time as you're also zeroing in on the more likely diagnosis of POTS or dysautonomia in this patient. And you know, it's interesting, my cardiologist took the bent that tilt table testing is very uncomfortable and symptomatic for patients like this and is not perfectly sensitive and or specific. So some may say just start treating and see if we can get the patient feeling better.
Interesting thought to just move forward with treatment in this patient. Some would argue if they meet the qualifications that they become tachycardic with rising from the laying to standing position, even in your clinic, and you're going with a tachycardia greater than 130 beats per minute with positional change, potentially that's sensitive enough to be able to diagnose and move forward with treatment. Curious, Dr. Courier, if you could unmute yourself and give your thoughts on long COVID and the cost of management of these patients, knowing that we have increased risk of heart failure, VTE, but also dysautonomia in this population. Would you do all of these tests given those risks, or would you be more tailored in your approach considering the most likely diagnosis in this case?
Yeah, it's a great question. I mean, the other thing that I was thinking about in a young person with new onset palpitations is whether there's any role for any kind of, cardiac monitoring, Holter monitoring, or even just using a active, like a Apple Watch or something, just to see what the heart rate is like. But I think when we think about the cost, we also have to think about the cost of people not being able to work and being, not able to contribute to society, and all the costs of all of the things that long COVID prevents people from doing, and not just the cost of the evaluation. But I think in this case, given that you already have these symptoms, I might pursue the workup and further approach to treating what might be POTS to see whether you can get some symptomatic improvement.
Excellent. Any other thoughts?
Tiffany, I think the other issue I would have when you talk about cost and missed opportunities is when you were presenting the case, as Dr. Curry was saying, was thinking about, okay, let's potentially think this is not long COVID, something else is going on. This a young woman, could she be hyperthyroid? Could she have something else? And I just worry that with so millions of people infected with COVID and so many people having COVID, we get anchored bias on, oh, this is long COVID, and we may be missing other diagnoses. So I'd like to go to see this patients with an open mind and try to not say this is so long COVID, but rather really try to work up the patient and make sure that other things I need to rule out that I don't want to miss. Yeah,
absolutely. And I think that's really the pressure that a lot of us long COVID providers are really struggling with is really how much of that workup do we do? And I totally agree with you, Dr. Courier. It's a very debilitating disease, and we want to be able to get down to the bottom of what's causing it, both from a pathophysiologic standpoint, as well as any sort of management approaches we can offer, and have often done the $1 million workup on this patient population. I think as we start to see more constellations of symptoms that are more common, then it gives us some information on how to move forward. And for my teaching points with this, my approach would be to move forward with the tilt table testing, although I would really consider doing a Holter monitor as well, Dr. Curry, because we are seeing a lot of arrhythmias in the absence of the clear POTS picture. But just show you, to Dr. Siegelman's point, not a very specific test, but it is rather sensitive. We're looking for that increase in heart rate greater than 30 or a max heart rate greater than 120. So just a point to make that this is a pretty common phenotype of long COVID we're seeing, existed, of course, before long COVID, a predilection for the younger population, the female population, but can occur at any demographic. So something to keep in mind. Moving on to the next question, how would you manage this patient? Let's just assume that this patient does in fact have POTS. Would you refer them for a rehabilitation plan that focuses on upright training techniques, increase water and salt intake, initiate midodrine, order lower extremity compression garments, initiate fludrocortisone, or potentially something else? All right, and if everybody has entered their responses, we'll go ahead and see what we have. All right, the majority would like to move forward with a rehab program that focuses on upright training techniques, less popular, but still there, water and salt intake, midodrine, and lower compression garments. So I will move to Dr. Zimmerman now, if you can unmute yourself. So this is a patient that is otherwise really quite healthy, although she does have hypertension. We are assuming that she has POTS as her phenotype of long COVID. How would you support managing this patient at this point?
Sure, thank you. So some of the available evidence suggests that a combination of some of these things might actually be helpful. An exercise type program, and plus increasing water and salt intake and ordering the lower extremity compression garments, I guess, as thinking about first line non-pharmacologic therapies that might be helpful. The risk of water and salt intake with her hypertension, should certainly be thought of. But thinking about maybe a combination of some of these things is probably a direction that I would go or start thinking about before adding additional pharmacologic therapies.
Excellent. I think you bring up a really important point that with dysautonomia and POTS, it often is a multimodal approach, and we have to take into account underlying comorbidities. Curious, Dr. Antar, is there anything you would add or anything that's not on this list that you would consider for your patient that has dysautonomia or POTS?
Yeah, thanks. Yeah, I think the only thing, so I completely agree with Dr. Zimmerman. I think the only thing that I have heard from the community of people with long COVID is to be really careful about exercise-based rehabilitation, because I think the post-exertional malaise, as Dr. Siegelman told us from his own perspective, can be really, really debilitating. And so I think there is some controversy around that in the community of people with long COVID. But yeah, I think my spouse actually has POTS, and so we've been dealing with that as a family for the last couple of years. And sometimes water and salt intake is what helps. Sometimes the compression garments help. Sometimes they don't. So I think, as Dr. Siegelman really eloquently put forward, there are, you try many things, you see what works for you. It's kind of a stepwise approach with hopefully a caring physician on the other end.
Yeah, and so it seems like you have a firsthand experience with this, and it's a very disabling disease, and unfortunately, especially when it's happening to this younger population that really didn't think they were at risk of developing severe sequelae of COVID. I think it's a very patient-centered approach, like you're mentioning. Any thoughts on a rehabilitation plan that would make sense for this patient? Dr. Antar or Dr.
Sure,
Siegelman?
Yeah. Well, so this is an area that I'll defer to Dr. Siegelman because he's lived through it. But This is an area that I think is under active investigation right now. So I don't have the answer for that right now, but I think this is something that people are very interested in.
So for me, I was recommended to start what was referred to as the Levine protocol or CHOP protocol, and there's a what it is a very slowly progressive exertion targeted exercise plan that covers about 9 months and slowly progresses you from recumbent exercise to seated exercise to upright training as you build muscle tone and other capabilities so that you can tolerate the sort of orthostatic change. And that was very helpful for me.
And
Wonderful.
Dr. Walker, can I just jump in here just for,
Yeah.
at the beginning, we heard that most of the people on the webinar are not actively treating people with long COVID. So just, I think it's really great to talk about what these protocols are, and are most physical therapy departments familiar with implementing this when you refer someone, or how do you guide the care for people to get this kind of rehabilitation?
Yeah, I think that's been one of the biggest challenges is speaking with other networks of long COVID providers. There are certainly physical therapists have expertise in dysautonomia, but I don't think that's true of all physical therapists and rehabilitation therapists. And so working with your networks and communities to increase capacity within your rehab specialists so that you can have those resources, because Dr. Siegelman is exactly right. I'm certainly not an expert in dysautonomia, but that's the approach. And so that was kind of a trick question, a trick answer. Doing upright training techniques is really not appropriate for this patient population. It will exacerbate their symptoms. And the approach for these patients is really recumbent exercise. So to Dr. Antar and Dr. Siegelman's points, and Zimmerman as well, this is a disease, unfortunately, that has been somewhat neglected in terms of research. We don't understand the pathophysiology fully, and we don't have many clinical trials in this disease to know what's effective. There are some observational data to support non-pharmacologic and pharmacologic options. So, and again, multimodal approach makes the most sense. So if you can withdraw exacerbating medications like diuretics, if they're not indicated, I think we know patients who have venous insufficiency don't really need to be on that diuretic. If you have medications that increase heart rate, like SNRIs or stimulants, increasing the oral and fluid intake if there's no contraindications. Salt intake can be challenging at that high of value, but you could try salt tabs. And then lower body compression garments will work for some and not all, but really I think exercise training with recumbent exercises that mitigate the effects of gravity, swimming, recumbent, cycling, rowing, all these things that Dr. Siegelman mentioned, with stepwise progression as the patient tolerates. And then I think some of us are familiar with these pharmacologic options. So mineralic corticoids won't be great for everyone, but fludrocortisone works for some. Heart rate modulators like beta blockers can be somewhat effective. Ivabradine is one that there's small clinical trials in dysautonomia. It does inhibit the SA nodal depolarization, so can cause bradycardia or heart block. So something to consider in conjunction with a cardiologist. Prostaglandin is quite common. Vasoconstrictors like midodrine, sympatholytic drugs like clonidine and modafinil. And so you can find these all online. You can reference these. They are not FDA approved, and there are mostly observational data. And this is, I think, an area that we really need to learn a lot more about. Any other thoughts from the group on these managements? Great.
All I would say is these are very difficult symptoms to manage.
Yes, very challenging disease, and unfortunately one that hasn't received the research that I think it warrants. So moving on to case number 2, this is a 52-year-old male with obesity, hypertension. He's vaccinated. He's coming to you 3 months after his second Omicron-era SARS-CoV-2 infection. Both of his infections were mild. His symptoms completely resolved after the initial infection, but then persisted after the second infection. He reports crushing fatigue that varies day to day and is worse after activities, so that post-exertional malaise that we talked about. He doesn't volunteer this, but when you ask, he has difficulty falling asleep and maintaining sleep. He has trouble with memory, foggy thinking, diffuse joint pain and back pain, and you do a comprehensive physical exam, the only thing you find on exam is a MoCA of 18 showing moderate cognitive impairment. Labs are normal with exception of inflammatory markers, elevated CRP at 12. Pretty classic long COVID patient. So how would you manage this patient's cognitive impairment, the one thing that you found on physical exam that is altered? And you can put in your responses at this time. And sorry, I should read them out. Refer for cognitive rehabilitation, start amantadine, start guanfacine and acetylcysteine, screen and treat for depression, start low-dose naltrexone or something else. All right, so refer for cognitive rehabilitation is the most popular vote here. Screen and treat for depression was consistent, and start low-dose naltrexone. So moving on to our panel. So I'll start with Dr. Zimmerman. You know, it's pretty classic that we will run into patients that have the full gambit of long COVID symptoms, and we won't have anything that we find objectively on physical exam or laboratory work, but we do find impaired cognitive impairment on or cognitive function on this gentleman. How would you manage his cognitive impairment?
Again, I think this is probably a multimodal approach. We certainly know that, you know, depression can coexist with cognitive impairment, or that there are kind of differing presentations of cognitive impairment depending on whether or not you are depressed or not. So certainly thinking about screening and treating for depression would be important. I also noticed that there was some sleep issues that were on your prior slide. And so I think trying to address some of that is also really, really, really important. And then thinking about cognitive rehabilitation would be probably the third thing that I would be thinking about, at least as an initial step, knowing that we're hopefully going to follow these people very closely, that we are really going to listen to them as to whether or not things are beneficial, and we can change our course if things are not really moving in the right direction.
Excellent, thank you. So I'm hearing a theme of multimodal approach, which I definitely agree with. Dr. Paredes, I'm curious, are you familiar with any of these treatments and any thoughts from a pathophysiologic standpoint of medications that might be effective in cognitive impairment on this list or other?
No, I completely agree with Dr. Zimmerman in the approach. I think that, well, all these several of these drugs have been evaluated, but I think that there's we never use them outside clinical trials. So what I think we should really do is to do clinical trials and generate the evidence. So very agnostic about all these drugs, and we never use them actually outside clinical trials.
Any other thoughts from the group?
Yeah, I just, again, kind of going back to this cognitive rehab, you know, can you talk a little bit more about what it is and where you find it? And also if it's, if these providers are able to get reimbursed for the services, I think it may depend on the setting that you're in. Is this often in a neuropsychologist or part of a memory or cognition unit in neurology? Can you talk more about what it is and how you find it?
Yeah, no, that's an excellent question. And I think that we have advantages when we're at an academic institution as opposed to community, which I think is partly your point. So a neuropsychologist can provide these services. Memory clinics that are run by neurologists or psychologists with expertise in memory can be very beneficial. Dr. Paredes makes a great point. So this is just an area where there's very little research right now. We have to draw on other overlap syndromes that we're seeing similar phenotypes in long COVID. I think of ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome. I definitely heard your point, Dr. Paredes, on your last Q&A about not necessarily assuming long COVID is something that existed before, but we definitely see some overlaps and can draw from some of our experience in other overlap diseases. And so what's been shown to be beneficial in that population is attention process training, compensatory strategies. There's a number of them listed here. We see the domains that are affected in long COVID are domains related to memory, processing, language, and sometimes executive function. And so a neuropsychologist can really benefit us there. There's evidence to support cognitive rest and cognitive pacing, which can reduce and control the symptoms.
So the one, if I may just chime in, one of the problems we have actually is providing cognitive care to all the patients, because we have tons of patients we do it usually with a neuropsychologist, and a neuropsychologist visit takes at least 1 hour, 1 hour and a half if they're fast. So I think so what we're trying to do also is to, but I don't know if they're going to be efficient enough, is to set up trainings that can be done online, and try to find ways by which at least patients can do some of the work at home. Otherwise, we are unable to cope with all the big amount of patients.
And I'd add, and we're going to hear more about this later from Dr. Zimmerman, there's sort of a recurring theme here about the need for research and the need for expertise and resources. And I think some of the infrastructure that's being built around the COVID trials for treatment will really help facilitate for people, being able to get into a setting where they can be evaluated and potentially participate in a study to help us learn what works and doesn't work. Because clearly that's what we need to move this field forward. But we'll come back to that at the end of the day. That's going to be our stick around for that part of the program.
Yeah, totally agree. And with both of your points, and Dr. Paredes, I think we all feel the strain in our consultants as well, and being able to see these patients. I won't go through these in great detail, but these are all under consideration for clinical trials. I mostly agree with you, Dr. Paredes, that it doesn't necessarily make sense to trial these in your patient population outside of a clinical trial. Although I know there are a number of people doing low-dose naltrexone, because we've seen it be effective in the ME/CFS population, and it's such a low risk medication at a low dose of about 4 milligrams that people are using this currently. The one point I want to make about mental health is that we know that depression, anxiety is an independent risk factor for cognitive impairment, particularly in our elderly population. But we do know that cognitive impairment is an independent process in long COVID that could be made worse by mental health. So screen and treat, of course, but not to hang our hats on it being the etiology of the brain fog, which unfortunately, I think a number of our patients have had that experience with providers. And there are studies showing that even as the anxiety and depression improves, a cognitive impairment persists. So to reassure your patients and validate them, yes, this is not just depression, this is truly a separate process.
So, Dr. Walker, just, sorry, say.
No, go ahead. Go ahead.
Just very quickly, when we started with our clinic, we did some systematic evaluations of depression and anxiety in all our patients. And what was very interesting is that few of them were depressed at the beginning, but when you follow them over time, then they become depressed. So it's not really the trigger. But depression exists, but it accumulates over time. That was my only point.
And we were going to say the same thing. I was going to just add or reflect that the frustration and hopelessness that comes with having an invisible illness that you're having trouble seeking care for can lead to its own anxiety and depression symptoms. And so, again, a chicken or the egg. I think in many cases, long COVID may come first, and this will accumulate over time. And the other thing I was just going to reflect on is, a couple months into my illness, I remember having a phone call with my personal therapist saying, look, I don't think I'm depressed, but I don't want to be my own doctor. And I'm having sleep trouble. I'm having fatigue issues. I'm not thinking clearly, and I'm not able to do my normal activities. So let's talk about this. Is this depression or not? And, we've mentioned a couple of times just staying open-minded. And I think especially for this ME/CFS phenotype, it is important to at least consider.
Yeah, no, I think those are excellent points. And you guys are saying the exact same thing I've heard patients say anecdotally. When you ask them, they feel like their depression is related to the disability, the lack of reassurance they're receiving from their clinician. So I think all of us want that one of the take-home messages for our audience to be really reassure your patient and validate them. Right now, that's probably the most therapeutic thing that we have to offer. Well, we focused on his cognitive impairment because as usual, that tends to be the only objective finding we see on exam. How would you like to treat his fatigue, though? That's the thing that's really bothering him. Would you like to counsel him on good sleep hygiene, refer to physical therapy for reconditioning therapy, start prednisone? start modafinil, a stimulant, or recommend physical and cognitive pacing strategies. I think we've already addressed a couple of these. All right, and let's see our results. So the cognitive pacing strategies, like we discussed before, physical therapy for reconditioning therapy, and sleep hygiene, which our audience has mentioned before. So Dr. Siegelman, I'll start with you. Your thoughts on approaches to managing his fatigue?
Yeah, I think that pacing is really key. We often wondered, my doctors and I, whether if only I were to sleep well, if everything else would fall into line. And that unfortunately wasn't always the case. I think pacing was really the thing that turned me around. And it's a hard thing to really understand that you may not be able to wash all the dishes in one setting. In one go, you have to wash a bit of it and then sit down before you start feeling bad, because that's the way this goes. You don't often have warning when you're about to crash. You have to be able to predict it.
And can you speak a little bit more? And sorry, I wasn't able to attend your talk. Did you mention what the delay feels like for you?
Yeah, for me, it's several hours. So it's, some people will find that their crash happens the day after or even longer. For me, it's typically been a few hours after the exertion, and then will last for several hours after that.
Yeah, and I find that's pretty classic when a number of the patients that I've seen, and it can be disproportionate, probably, as you mentioned, where the fatigue really does not relate to the level of exertion that you put into it. Dr. Antar, any other thoughts on these starting medications for these symptoms, or any thoughts on reconditioning therapy versus pacing therapy?
Oh, thanks. Yeah, I mean, I agree with Dr. Paredes where, if there's not good evidence for medications, then there's really no role to start them. And, but it's interesting, actually, when I do talk to long COVID, people with long COVID, whether they're my cohort or outside, I am seeing them telling me that their general practitioners are prescribing them prednisone, which is an interesting thing, but, definitely not something that's at this point in time backed by evidence. But that's why I'm so glad that Dr. Zimmerman is, and others are leading the effort to actually have real clinical trials of these things. Yeah, counseling on good sleep hygiene. Essentially, that when I read that, it's like you must ask the patient first what their sleep hygiene is before you would counsel them. So, just like Dr. Siegelman was saying, you really have to take a good history. You have to humble yourself, really try to understand what their experience is like. Before counseling. But
I think it's really important. I tell patients that you really have to learn to listen to your body. I think Dr. Siegelman said it very well. There's some good days, there's some bad days. You need to not, overdo it. You need to, when it's time to say I need to take a break. I think the anecdote, the way you described the relationship with your child about understanding, which days are good, which days are bad. I think that's a really important process here in order to prevent, frustration and to really have the support that you need around it. But I also say that this is very important for patients to realize that their employees need to understand this, right? I mean, I think Jeff talked very well about how his colleagues in the emergency room, he realized what he's doing, what's going on, and can be supportive there. And I think we have to really understand this, because this is not an easy thing. And in fact, it's something that, I've been involved through the national academies with many discussions with Social Security about this. This is a major issue that Social Security really is looking into. How do we evaluate these patients? What is disability? When does it apply? At what point in time do you treat this as disability? And I think there's a lot of questions here, and there's a lot of still to be understood and to be discovered.
Yeah, and can I just jump in too? Because I just think, to think the cognitive pacing, I think, is something that is really hard for people to do. Like, I'm trying to imagine, Dr. Siegelman, this do nothing at all moments that you have to do to rest, right? You can't read, you can't work, you can't be physically active. I mean, how do people, just learning how to meditate or are there other activities that people can do during these downtimes that are restorative in some way? Because it seems like you go crazy.
It is a challenge, and gratefully mine was never that severe that I had to do dark room, blinds closed, and nothing. However, yeah, it is not intuitive right away that watching TV or doing a crossword puzzle would be something that's enough exertion to make you physically weakened for several hours, and really it's hard to just connect those dots and really understand that for yourself.
Yeah, I'd like to highlight something that you said, that the cognitive load can be sufficient to cause this post-exertional malaise. It doesn't need to be a physical load, and to recognize that as a clinician is important because it doesn't necessarily fit an illness script for us before long COVID. And again, validation, I think, is really key for these patients. The points I was going to make, I think, have already been made, that essentially you have to grade your exercise or cognitive load based on your experience with your own post-exertional malaise, and that can be helped with a rehabilitation specialist in this area. Particularly, this patient has more of that ME/CFS phenotype, and that's really the best approach at this point. We don't have clinical trials in this phenotype or evidence for those other medications. Moving on, sticking with this case, so the patient's wife is in the room with him, and she says, I don't know about all this long COVID stuff. He's already had COVID before. Shouldn't he have gotten long COVID with the first infection if he was going to get it at all? So how would you respond? Would you say, well, if you didn't develop long COVID with your first infection, it's possible, but really pretty unlikely you'll actually develop it with subsequent infections. Typically, if you get it, you're going to get it. Or B, the risk is the same regardless of the number of infections. C, each subsequent infection increases your risk of developing long COVID. D, we don't have any studies that have looked at this yet, but it's something we're very interested in, or potentially something else. Let's go ahead and take a look at our results. Each subsequent infection increases your risk of developing long COVID was the primary choice, but as others think that potentially we haven't looked at this yet. So Dr. Paredes, based on your knowledge of vaccines and long COVID risk, do you have any thoughts on how you might counsel a patient?
So at the individual level, each new infection is an increased risk. This has been seen. So even if you had three acute COVIDs in the past, you can still start the long COVID in the fourth episode. So patients should not be. Then at the population level, it could happen that overall, as more people are being exposed, more people are being vaccinated, so on and so forth, maybe the immune system is getting trained. There is discussion. I've seen some data in cohorts showing that it depends on whether it's prevalent or incident new infections. But just to make a story as clean as possible, I think that I would advise them that yes, they can still have. So each new infection increases their individual risk of long COVID. They're not protected.
Yeah, but I would add that I think every wave has been different, right? I mean, it's very different to have the original strain, like what Jeff had. Never had it, no immunity. We saw a lot more people develop long COVID then. I think if now you have a population that either it's immune, I mean 90+% of the population is immune either through vaccination, through acquired infection, a combination of both, hybrid immunity. The virus has changed significantly. So if you look over time, not every exposure is the same because the host has changed and the virus has changed. And I think therefore it's really hard to answer this question. I would have said here, quite frankly, we don't really know because it changes every time, Yeah, you're not immune from getting long COVID, but I'm not sure your risk necessarily increases.
No, I completely agree at the population level, but then at the population level, possibly we will be seeing that it's clear that most of patients being seen in our clinic come from the first wave when the immune system was not trained, they were not vaccinated. So I'm sure that we're getting better, and overall also that people, whichever risk factor or host factor is there, after a high number of exposures, I mean, possibly overall your risk decreases, but it should not be. In no sense we should tell them that they are protected from getting long COVID.
No, I don't think you're
that was my
protected.
point. Yeah,
I don't think you're protected, but I'm not sure you necessarily have a higher risk every time you get COVID. I mean, I think you have a risk basically.
Yeah, I think though for this participant, this patient and his wife, the idea that this could maybe not be long COVID because he didn't get it the first time is really what we want to dispel.
That's an important point.
You didn't get it the first time, you can still get it if you get
Yeah.
COVID again. I think
Correct.
that's a really important public health message.
yeah.
Yeah, and we'll see this. We'll see people believing that either you're going to get it or you're not going to get it. And I've seen data to support both what Dr. Paredes is saying and Dr. Del Rio as well. So there's been studies looking at your risk of developing long COVID with subsequent infections and looking at it by individual symptomatology or disease or organ system, and it was increased for all. But paring down a little bit more, looking specific to variant type, and the recent study coming out of Recover, it showed that higher rates of long COVID in those in the Omicron era with subsequent infections, but it wasn't really necessarily true in those pre-Omicron. Just looking at rates alone. One of the questions could be to Dr. Del Rio's point, maybe in the pre-Omicron period, you had such a higher risk of developing long COVID from the virology of those viruses that those patients were more likely to develop it from that variant as opposed to subsequent infections that may have been Omicron. So probably the answer is we don't fully know that, but the answer. But I do think the counseling to patients on a more layman's level would probably be increased risk with subsequent infections. Sticking with that case, the patient chimes in and says, well, I've been telling my wife that she should get vaxxed too, but she just won't listen to me. Maybe you can talk some sense into her. She hasn't had COVID yet. Does the vaccine provide some protection against long COVID? So how does the vaccine play a role in this? You say, yeah, the vaccine prevents long COVID entirely, or you could say the vaccine seems to really decrease the risk of infection and may decrease the risk of developing long COVID. The vaccine increases the risk of developing long COVID or has no impact, or something else. All right, so I think the majority of people feel that, as we know, it decreased the risk of the acute infection, and we believe that it will decrease the risk of developing long COVID. Dr. Currier, I'm curious your thoughts on how you counsel patients on the vaccine, not only for prevention of severe acute COVID, but any implications it would have for long COVID.
Yeah, I think given where we are with our both diagnostic and therapeutic approaches for long COVID, the one thing people can control, or two things, is trying to reduce their risk of getting COVID, but by getting vaccinated, that is something that you can do. And I think it's not going to be 100%, but you're hearing all the frustration with making the diagnosis and having treatments to offer. If you could do something to prevent it, I think people would want to take advantage of that. And it's disconcerting that it continues to remain, levels of vaccination continue to remain low despite an ongoing pandemic. So.
Yeah, and Dr. Zimmerman, it seems that most people have made their mind up about this vaccine, whether they're going to get it or not. But there's potentially a population of these younger patients, particularly the ones that could go on to develop, say, dysautonomia that could be really disabling. Your thoughts on approaches to counseling them on use of vaccine if they haven't gotten it yet?
Sure. I mean, I think Dr. Currier's rationale that she just presented makes probably the best sense, that, because of the concerns and the potential risk associated with acute COVID and then long COVID, and the fact that this may be a prolonged debilitating disease in someone who is normally active, et cetera. This is the one thing that we know can potentially prevent. So I think the fact that there aren't really a lot of other options is the rationale that I would really lean on, as Dr. Currier mentioned.
Tiffany, and I tend to use this as a way to talk people into getting vaccinated, especially young people, because I think if you heard in Dr. Siegelman's talk, it's striking what an important and debilitating symptom the loss of smell and loss of taste is. And you can tell a young person, yeah, you may not die, but you may not be able to taste anything or smell things for 6 months if you get long COVID. That gets their attention. That beer is not going to taste like you like it. That's going to get their attention. And I've used this frequently to tell people, you know, vaccine may not prevent it, but it will decrease your risk. So, you know, you don't want to get COVID, because if you get long COVID and you develop the anosmia, it's not a fun symptom to have.
Yeah, absolutely. And I think that's really the approach to consider in these younger folks. Dr. Antar, have you had younger patients who aren't as concerned about their risk and then have gone on to develop long COVID?
Yeah, good question. So my practice is in people with HIV, and it actually mirrors, I would say, the HIV population in that most of my my patients are older. I do have younger patients who have not got vaccinated, and they have their own reasons. I usually, you know, try to tell them, yeah, my approach is to counsel them why I think it's important. So decrease the risk of severe acute COVID. And I say, you know, there is some risk decrease to getting long COVID. And I describe that, and I'm studying long COVID in people with HIV. So I have things to tell them. But then I think you want to have other answers for them that might be acceptable to them. So if they've decided against vaccination, they're usually not going to do it. So one thing I will say is that, you know, there might be some emerging data that things like Paxlovid might help decrease your risk of getting long COVID. And so I tell them, if you think you have COVID, you test positive, call me. I will prescribe you an antiviral. And if that decreases your risk of long COVID, I'm happy to do that. And I know we all know that it decreases the risk of being hospitalized for COVID as well too. So I think it's important to meet them where they're at, provide education if they're not, you know, if they've made up their mind, then provide other alternatives that might be acceptable to them.
Excellent. That's a great answer. So looking at the data, as you guys have mentioned, so there by different modalities, there's one study looking at long COVID risk following vaccination, showing decreased risk in both mechanisms studied. And then again, out of the recover cohort, we see, interestingly, both the pre-Omicron era as well as the post-Omicron era, we're having lower rates of long COVID in those that were vaccinated prior to infection. Okay, so we'll move on to a new case now. So this is a 61-year-old female with uncontrolled diabetes, heart failure with a preserved EF, and hypertension. She's coming to you 12 months after a Delta-era SARS-CoV-2 infection. She's had fatigue ever since COVID-19. It's been persistent. She's not quite as concerned about that. She's worried about crampy abdominal pain for the past month, early satiety, nausea, decreased PO intake. She's had an intermittent diarrhea, not every day, but some days, and it'll be 3 to 4 bowel movements per day. She only notices blood on the tissue while wiping, but it's not mixed in with the stool, and it's not in the bowl. Her exam reveals mild abdominal tenderness to palpation, no blood in the rectal vault, and her labs are within normal range, with the exception of some anemia with a hemoglobin of 10, a low MCV, and elevated inflammatory markers, CRP of 15. So what's the most likely cause of her GI symptoms? Functional dyspepsia, inflammatory bowel disease, COVID-19 enteropathy, irritable bowel syndrome, small intestinal bacterial overgrowth, or maybe something else. We think these GI manifestations have been present in long COVID, but just haven't had the awareness until more recently in recent studies. So what do we think this patient has? And let's look at the results. So COVID-19 enteropathy, we see that in HIV and other viruses. Could that be the case in this patient? Dr. Siegelman, have you been noticing as patients are coming into your ED with long COVID symptoms, you're probably particularly adept at recognizing this constellation of symptoms. Have you been seeing GI manifestations in your population?
For sure. Actually, one of the patients that stands out the most for me is a patient who had been incarcerated and had this was back in the early days when there really wasn't testing, had a febrile illness, lost of smell taste, and then had several months of diarrhea and abdominal cramping, and just like this, loss of energy, and now was out of jail and trying to get work, but couldn't because he was so overcome by his GI illness. And I think that he was the first that I saw like this that was long COVID, probably long COVID with a GI source.
Yeah, and when you're seeing these patients, do any of these jump out to you as potential causes? Are you seeing this this constellation similar to any of these other diseases that are already well identified?
Sure, and especially in the age group of the woman that's presenting the case here, I mean, lots of other things come to mind, and this is, I think, a good example of a moment where we have to stay broad before blaming this on their COVID infection. 60-year-old woman with early satiety and some blood in her stool has a lot of things that are much more scary running through my mind.
Yeah, I was going to say that too. I think ruling out colon cancer would have to be high on your list in this age group with those symptoms. So I think that's a really important lesson, is not to just jump to what might be from long COVID, but putting on your, general practitioner hat first.
Yeah, that's excellent. I really like that. I think since long COVID symptoms can be so vague, it's very easy to attribute things to long COVID without looking into other more common diseases. And then, Dr. Paredes, given your knowledge and understanding of pathophysiology, do any of these jump out to you?
No, I would also prioritize colon cancer as well. I think that enteropathy is really a hallmark of acute and post-acute COVID. It happens very quickly, actually, possibly thinking about where the vagus nerve becomes infected with, maybe it's in the gut, actually. Who knows? That's an hypothesis. So because enterocytes are really very actively and quickly and easily infected, and enteropathy is very frequent during acute COVID, and also during post-acute COVID. But here you see everything is possible, but it's 12 months since the acute COVID-19. There's blood in the stool. It could happen. I hear a lot about SIBO, and I have a hard time understanding what it is exactly when it applies to these patients. So I certainly wouldn't think about that one. And it may be irritable bowel syndrome, might not be the exact age range, but I would certainly rule out colon cancer here.
Excellent.
Yeah, no, I agree. I do think though that irritable bowel syndrome has been described as almost a dysautonomia kind of phenomena in some patients, and but I always like to think that as a diagnosis of exclusion. Again, in this patient, I would go to a colonoscopy, endoscopy, many other things, because I emphasize what Dr. Courier said. We don't want to miss. I've seen way too many people already that they were told they had long COVID and they had something else that people had not seen, had not picked up. So I think it's really important to not go with the blinders of, oh, this is long COVID and let's forget about everything else.
Yeah.
Excellent. Yeah. And so I totally agree. This patient really warrants an endoscopy for age-appropriate cancer screening, especially with some bleeding. We are seeing that irritable bowel syndrome is more common in those that are COVID exposed versus control. The data are not overwhelming, but we're starting to hear more about it, see more reports of it. You see here in this figure that it's statistically significant irritable bowel syndrome. And for some people, it can be pretty disabling. I've had some that are extremely uncomfortable, can't eat anything. And so what I'm trying to describe in this case is a patient that has kind of that mixed picture. So they're not having diarrhea every day. I didn't speak much about their constipation, but in this patient, they were having some straining with their stools in between. And so consider inflammatory bowel syndrome. I agree, you can see this in dysautonomias. The question of whether or not we can see inflammatory bowel disease, I haven't seen that or seen reports of it yet, but of course we have heard mention of autoimmune dysfunction in COVID. So things to keep in mind. And yeah, the COVID-19 enteropathy tends to be more the acute phase. I will mention in this study, this was at a 12-month time point, but there was no statistical significance at a 6-month time point. Interesting, unclear the cause of that, but it may speak to the underlying physiology of what's going on. We do see delayed onset of new symptoms in long COVID that may not have been present early on in the COVID or early post-acute phase. Okay, so moving on, we have a 34-year-old male. He has very uncontrolled diabetes. He has obesity and obstructive sleep apnea. He's coming 3 months after a mild acute COVID infection with symptoms of long COVID that have persisted since the infection with fatigue, weakness, and brain fog. He's developed new back pain 1 week ago, and that's really what he wants to talk about. Sudden onset that's really progressed to 9 out of 10 pain associated with radiation to his right anterior thigh. He has some abdominal pain and nausea. You do a thorough exam and you notice that the abnormalities are he is febrile at 38.5, no abdominal tenderness palpation, but he does have pain with extension of his back. And when you saw him walk in, he had a very antalgic gait. His labs are unchanged from previous, and his spine x-ray you checked was normal. What's the next best step in management for this patient's back pain? Would you go ahead and check that CT spine, or would you treat his pain with opioid analgesics since it's really quite severe, refer to physical therapy to improve range of motion and decrease pain, start gabapentin for neuropathic pain, refer to pain clinic for corticosteroid injection, or would you consider something else? All right, we'll go ahead and look at our responses here. Check a CT spine as the most popular, or potentially refer to physical therapy. So Dr. Del Rio, looking at this constellation of symptoms, are you concerned? What are your thoughts, and how would you move forward in managing this patient?
You know, back pain and fever are two things that an infectious disease doctor I get very worried about, because, you know, epidural abscesses and other things can lead lead to paralysis very quickly. When I have somebody with fever and true back pain, and especially nowadays, and you know, we have a lot of people using injectable drugs, opioids and other drugs. I think I may, you know, CT spine is a way to go, but I may even go directly to an MRI. I mean, this is somebody I want to be absolutely sure they don't have an epidural abscess, a discitis, some reason to explain that fever and back pain.
Yeah, excellent. Dr. Currier, your thoughts?
Yeah, and I think also the acute onset and the radiating symptoms really suggest there could be some nerve compression. So I'm completely on board with the ID approach here to getting the CT scan or MRI.
Yeah, I was trying to throw in a trick question here, which you guys all picked up on. And it's the point that we've been making throughout this presentation. All these symptoms are consistent with long COVID: fever, fatigue, back pain, joint pain, brain fog. And the most recent study we mentioned before out of the RECOVER cohort shows that these are more common in COVID exposed patients versus those without exposure to COVID. But it's really the urgency or the emergence of the symptoms, the acuity of them, and the association with a fever. So not to hang our hat on the fact that these are all symptoms of long COVID. If you have a constellation of symptoms that to you puts up your red flag, really consider these other diseases. And even in diseases that aren't critical illnesses, if it appears to be something else, like we talked about, could be colon cancer, then we want to screen for those things and not just use long COVID as the diagnosis we hang our hat on. Great, I think we have time for one.
And I think Tiffany, just goes back to emphasizing what has been said also over and over. You have to be a really good internist, a really good general practitioner to see these patients. I think sometimes I worry that if they go to a subspecialist, they're being seen by a cardiologist or pulmonologist, some of these things may be missed. And that's why I really think this is, the multidisciplinary approach is great, but you need somebody who's a true internist in the evaluation of these patients.
Yeah. I think that's critical, Carlos. There has to be someone in the middle that actually coordinates everything. It's not just, and this is hard to make it understand to some people who decide on healthcare structures, because they, at least in our region, sometimes it's like they already have a cardiologist, they already have a neurologist, and that doesn't work that way. Yeah.
All right, we'll try and squeeze in one last question. So we have a 61-year-old male with hepatic cirrhosis admitted to the hospital with alcoholic hepatitis and hepatic encephalopathy. He's gotten much better. He's in the hospital awaiting placement. He's previously vaccinated. Unfortunately, he starts to have some mild viral respiratory symptoms, and you test him. Sure enough, he's SARS-CoV-2 positive for the first time. Fortunately, his SpO2 is 97% on room air. His exam is within normal limits. His lungs are clear. The only findings are as known ascites and stigmata of cirrhosis. AST is 152, ALT is 80. His T-billy has come down quite a lot from 28 down to 18, but it's quite elevated still. And his INR is 2.1. How would you like to manage his acute COVID infection, taking into account a lot of the things that we've discussed today? Would you withhold treatment? He's just a little too complicated. Would you start nirmatrelvir and ritonavir, which is known as Paxlovid? Would you start molnupiravir? Would you start remdesivir, or potentially take another approach? We'll go ahead and see our results. So it looks like nirmatrelvir and ritonavir, so Paxlovid was the win. Some considered remdesivir, and we're a little bit all over the place. So I'll start with Dr. Zimmerman. Your approach to this patient with severe hepatic impairment, how would you move forward with treating his SARS-CoV-2 infection if you were to treat it?
I would be fairly concerned about nirmatrelvir and ritonavir, given known concerns in hepatic insufficiency in this particular population. I would potentially think about starting molnupiravir, although this patient is fairly high risk, but in an okay situation right now. Certainly remdesivir, there's concerns about liver dysfunction as well. So those would be my initial thoughts. It's not straightforward.
No, it's not. And this was my case 2 weeks ago. So Dr. Currier, your thoughts?
Yeah, I mean, it's caution, right? Caution using this for treatment. And I think that's a clinical judgment, and make sure obviously they're not on any other contraindicating medications. And I think that, we talked about the rationale for using treatment as the hope that you not only reduce the risk of hospitalization and death, but prevent long COVID. And so I think there's some compelling data from observational studies on nirmatrelvir, ritonavir. Interestingly, in the prospective trial of 2 monoclonal antibodies, the BRIE-BIO antibodies that significantly reduce hospitalization and death in active 2, we did not see a significant reduction in self-reported 13 symptoms of long COVID. Now, maybe monoclonal antibodies are different than antivirals, but I think this is an area where we really need more research, and we need to agree on what these endpoints are so they can become endpoints for clinical trials of therapeutics. And, as Dr. Paredes said before, with rates of hospitalization at 1%, we're never going to get any new drugs approved based on that. So we need to think about whether long COVID could be an indication for approving a treatment. So that's kind of getting a little far off the spear here, but I definitely would consider treating, and I might cautiously use nirmatrelvir, ritonavir.
Excellent. Dr. Del Rio, this patient is a captive audience. They're inpatient. Would you consider remdesivir in this patient?
Yeah, I mean, I think remdesivir would be my choice here. It's easier to administer inpatient, et cetera. But I would say that the studies that we have of decreasing the risk of long COVID are with nirmatrelvir, ritonavir, and also there's some data with molnupiravir, but we have no data with remdesivir. So I mean, I think this person needs to be treated just because they're 60, they have liver disease, they have a lot of reasons to treat them to decrease the risk of ending up in the ICU, and I would start thinking there rather than thinking long COVID, and therefore I would go with remdesivir.
Excellent. And that's a choice that we chose, considering that Paxlovid is excellent at decreasing risk with a relative risk reduction of 89%. Molnupiravir, we don't hear about it as much because it was really about 30%. Remdesivir is at about 80%. And this is all for acute COVID. Like Dr. Del Rio mentioned, the data in potentially decreasing risk of long COVID is in Paxlovid. Although hopefully there should be some observational data on remdesivir showing that as well, published soon. So yeah, I think as we've mentioned before and was mentioned in the previous Q&A, I think it's important to take into account the risk of developing long COVID in determining how you're going to manage these patients as well, keeping in mind that the data are still largely observational. And so we've gone over our time just a little bit. We're going to jump right into the Q&A session, and I will moderate that. So the first question is coming, says, is it time to call this chronic COVID infection so as to guide treatment and development? I'll start with Dr. Antar and get your thoughts on calling it chronic COVID as opposed to long COVID.
Yeah, that's a good question. I think, I think some infectious disease doctors, including myself, would be a little hesitant to call something a chronic infection if we don't have evidence that there really is chronic antigen or replicating virus in the host. And I think while there is some suggestive data that some people with long COVID might have spike antigen in their blood, and there's some evidence that there could be some antigen in the gut as well. In my own cohort, we've looked at that and haven't seen it. I know they've looked at it in the link cohort as well too, and it's not present in everyone. So I guess I would just hesitate. And the other thing is, I think, we should always be like following patients in their lead. And so it seems to me from, my reading and conversations that long COVID is the preferred term for symptoms. And then we call, the umbrella of sequelae, post-acute sequelae. But yeah, that's my take on it. But I really
would just,
others might have other opinions.
I would just say that I don't like the term PASC. Whatever. I think it was Tony Fauci came out with that acronym. It just doesn't stick. And patients come and talk about having long COVID, and this is, in fact, that's the title we use for the webinar, because that's what everybody calls it. So I don't necessarily think, and I agree with Dr. Antar, that chronic COVID infection means there's some ongoing infection, and I still need evidence of that in order to call it that.
Dr. Siegelman, any other thoughts as our patient representative and also a clinician?
From the patient side, yeah, I know that the patient advocates who came up with that term feel strongly about it. They published the origins of that name, and I would say that the community definitely identifies around it.
Excellent. So what exactly is cognitive rehabilitation, and how would patients access that referral to neurology? And so that's something that we addressed. My experience is that the neuropsychologists oftentimes offer that, but if you have a memory clinic within your institution, those experts usually are familiar with cognitive rehabilitation approaches. They tend to target the cognitive domains that are impacted in long COVID, which there's a number of studies characterizing. Granted, those are very small observational studies, and they mostly are about pacing and about compensatory approaches. Does anybody have anything else to add? Dr. Paredes, I know you have some experience in this.
No. I think that's exactly.
Another question, what do you think about anti-inflammatory diet for treatment of fatigue? So Dr. Paredes, is there any support based on your understanding of the physiology that an anti-inflammatory diet would help, and what would that mean?
No, I also do some microbiome research as well, and I think it's that maybe I do too many things though. But I think that diet is one of the most complex issues. I think that physicists should really evaluate diet. It's extraordinarily multidimensional, and it's easy to tell patients, yeah, you should do an anti-inflammatory diet, but I don't know exactly what's that. And we just recently saw, reports from the WHO recommending sugar again instead of sweeteners. If you do, I think it's too variable. I think it's good to do research. I think we underestimate the complexity of diet many times. So clearly, as of today, I would not recommend anything like that.
Yeah, I've been hearing a lot from patient advocates about low histamine diets or histamine-inducing foods. There's no studies that I'm aware of that would speak to
no.
those.
So one of the, and I might be a little bit too radical, but one of the things that we learned during COVID is that actually treatments can do harm. And then our first, oath, the Hippocratic oath is do no harm. So if you for example, use prednisone in patients and you don't have good evidence, there's also risks. So I think that everything that we recommend to patients should be clearly backed up by science, or at least by whatever it's closer to a randomized clinical trial or observational measures. So and we need to be very, very strict on that, because it's on patients' rights only to recommend what we have evidence, and do as many clinical trials as we can, of course.
Yeah, I'd like to jump in. Yeah, so I agree that right now there's no good evidence that a particular diet will help with long COVID per se. We actually have early evidence from our one of our cohorts. So I run 2 cohorts that total over 500 people. And we look specifically what puts you at risk for new or worsened fatigue, just that question that this person is asking. And we looked at a number of factors, including comorbidities and sex and all sorts of things like your D-dimer, CRP, other things. And actually one of the things that stood out was the number of fruits and vegetables that you have in your diet before you got COVID, which was like interesting and surprising to me. So basically the people who were eating more fruits and vegetables were less likely to get fatigue after COVID in one of our cohort studies. And in this cohort, just for the context, is mostly vaccinated and mostly in the Omicron era. So I think it's like somewhat applicable to today. And I think, just what Dr. Paredes is saying is, we shouldn't prescribe things for long COVID that, we wouldn't prescribe for anyone. But actually, there is great evidence that the Mediterranean diet, which is mostly an anti-inflammatory diet, decreases your risk of cancer, decreases your risk of diabetes and heart disease. So I think I actually talk to my patients about diet a lot in the clinic, because I think diet is the best medicine. And yes, I think if you eat more fruits and vegetables, more whole grains, less refined sugar, less meat and dairy, then yes, you're going to be healthier, you're going to have less of these diseases. And then we have this kind of early emerging data about this too.
Excellent. Thank you for sharing those insights, everybody. We've gone a little bit over our time, and so I believe now we are going to move on to a break. A lot of good questions in the chat that hopefully we'll be able to get to later, but thank you so much for joining us for this discussion panel.
Yes,
Well,
go ahead, Carlos, go ahead.
No, thank you, Tiffany, and thanks everybody. I think this was a very, very useful discussion, and I think it really brings home a lot of the points that we want to get. We're going to have a 15-minute break, and it has to be an exactly 15-minute break. We'll come in at 1:45 Eastern time, and at that point in time, Dr. Antar will do her presentation. So take a break right now, stretch out, get some water, and we'll see you soon.
Thank you. Bye.